Das ist, was können die?
Bis jetzt 10.
Ah, ist gut. Ist gut. Das sind ja noch gar nicht alle da. Eine ganze Menge Leute, die noch nicht da sind. Wollen sie nicht. Ah, hier.
Doch. Hallo, guten Tag, Herr Spitzen.
Hallo.
Aldar ist mein Name. Wir warten auf den Start.
Hello,
Ja,
sir.
kein Problem.
For a long time I haven't seen you. Hello.
Dr. Hassanain, how are you?
Perfect.
Thank
Very
you.
good. So now I think we should start. Imad?
Yes,
Can
sir,
you
we can start.
recording? We can start?
Yes, sir.
Okay.
Yes, sir,
So
it's
we
fine.
go online now. Perfect. So, well, good afternoon to everybody. It's a pleasure for me to have this webinar of the World Spinal Column Society. It's a wonderful webinar this time. It's focusing on the cervical spine. And I'm very happy that we have changed the format a little bit. So we will have 2 presentations and then 3 cases. So it will be a lot of information, but I think it's better because then we have the basis to discuss the cases. So I'm very happy that I have 2 experts for cervical spine surgery. And the first one is Tobias Spitzen. He is a very experienced spine surgeon, has been actually graduated from Hamburg University, but before I was here, so long ago, before spine surgeon in Eastern Germany, and now he followed the Hans in Karlsbad Langensteinbach. I think maybe for 15 years now he is there, the head of spine surgery, neurosurgery. So it's a real pleasure. He's very experienced. He has done a lot of research. He has worldwide expertise. So Tobias, I hand over to you to give us your presentation on the cervical, craniocervical junction and pedicle versus lateral mass screw placement.
Yep. Thanks, Joachim. Hi, everybody. Can you hear me? We got some little problems with the microphone here, but I hope you can hear me. Is it yes?
We can hear you, yes.
Audio is very good. It's very good.
Super. Okay. So, yeah, with the slides, I do not know. Do you know how that works here so that you can see? Look at that. It is now okay. It's much too much.
Go on the presentation mode.
Yep.
Down.
This one?
Yeah, there.
Thank you.
Yeah, that's it.
Thank you, Joachim. Thank you. Okay, so let's start. As you said, it was wished to present cases on the basis on that, to talk a little bit about the cervical spine posterior stabilization, including the CCG. And let's start with this case. This is a 18-year-old male with a severe neck pain following a struggle with friends. He had a kyphotic and tilted head position and then a destruction of the caudal clavus down to the body of the axis. You can see that here on the left side, it's a CAT scan. On the right side, it's the MRI. I see my friend Hassani there. We have been operating on cases like that several times, but this was very special in several aspects. So here is more information on MRI and CAT scan. You can see that the lateral mass in the atlas is destructed enormously, and that vertebral artery on the left side, at least on the left side, is included. So you can see it on the right side here, on the left side, it's somewhere in between. So it's a big mess. I think we have to think about patients in detail. The first question we have to answer is, do these patients need surgery, yes or no? I mean, that's the reason why we are here, yes. But if yes, how to start? What levels to be included? Do we go back, front, both? What type of implants do we use? And is there any place or necessity for additional treatment? How to start and levels to be included is probably one of the easiest questions. I think everybody of you will agree when I say a biopsy is a must here to treat these patients, because we have to know what tumor that is. I, from my personal experience, was confronted with that type of tumor for the first time in my life This was an inflammatory myofibroblastic tumor, a very rare entity on the spine, even more rare in the craniocervical junction. So there have been just a handful of cases published all over the world. However, it is aggressively growing entity. And I thought due to that destruction mass, it was mandatory to fix and realize and stabilize the cervical spine from the occiput down to C4, 5, or 6, just depending with the caudal end of the fixation on the bone quality and the resulting screw torque. I think everybody could agree here. So this is what we did in the first step. So we just took that guy, got him in the OR, did the biopsy, and then fixed it because it was terribly unstable. And now, if you do that way, you have further time to plan further treatment. The type of implants I used up to now here, so that's why I call it part 1, is occiput-bladed screws because the occiput is involved. And then I use lateral mass screws C1 to C5 due to the good bone quality. But I think the much more important aspect here was that the tumor involves the left-sided vertebral artery. I could show you that. And taking into account that you could hurt the vessel during resection, which would be, I think, very probable, and it was really the case, then it's probably better not to use a pedicle screw due to higher risk of hurting the vessel also on the other side. I think that makes sense. You can see this is not just something I experienced. This is from a publication from Neo in 2005 about the clinical risk of vertebral artery injury from the cervical pedicle screws inserted in degenerative spine. And you see that the pedicle screw can harm the vertebral artery. And what the authors concluded is that the deviation rate of the cervical pedicle screw placement is not very seldom, and they strongly recommend, if you do that, use a computer-assisted navigation system, or today, robotics. We can discuss about that later on. Concerning occiput screws, I think it's much more or less traumatic, especially for neurosurgeons, but you should be familiar with the anatomy of the occiput, which is thickest in the midline, and that's why I consider good systems with occiput blades to fix the screws exclusively in the midline, not laterally, exclusively in the midline, because the bone is here thicker. Here are some X-rays and CAT scans post-op, so not from this patient, but from other patients over my time, concerning the fixation of the occiput straight into the midline. What is also important in occipito-cervical fusion procedures is that you have to check the sagittal alignment and the gaze. So if you fix the occiput straight to the spine, then usually the gaze is horizontal and forward. If you recline too much, then the gaze is towards the sky. And if you incline it too much, the gaze is towards the bottom. The latest one is very, very dangerous because this has immediate implications for dysphagia and apnea. And we know that a reduction of the occiput C2 angle of more than 10 degrees results in a relevant dyspnea and dysphagia. And this is possibly life-threatening. If you're not familiar with that, please read these 2 publications which are mentioned here. Concerning the strength of pedicle screws, it's quite clear that pedicle fixation is stronger than facet fixation. I mean, it's quite clear because these pedicle screws are just double as long as the facet fixation. But facet fixation is sufficient in the presence of good bone quality and especially in the presence of an anterior support. So if you insert a cage or a cage with a plate, then you can be sure this will be, I would not say bulletproof, but it's probably very, very close to an isolated pedicle screw instrumentation via posterior approach. So it comes from my clinical experience of about approximately 30 years. Concerning complications, it's very clear, facet screws are much more or less dangerous than pedicle screws. You can check these results by Checon, and you can check the paper by Kass and Berm in the European Spine Journal. They describe pedicle screws in the C-spine to be misplaced by approximately 30%. The other question in our case, and we go back to our case in the clinics, is back, front, or both, what type of implants? So part 2. Back, front, or both is easy to answer. It depends on the localization of the tumor. This tumor is located back and front, so you go back and front. But the thing is, you have already closed the wound, so you have to reopen the wound. You have to resect the tumor by a posterior approach, and we, in a very initial step, did an endovascular embolization and then removed the tumor step by step. And then in the same day, we did a high anterior approach and anterior section. And we here used no titanium implant, but an autologous fibular graft fixed with a small bone plate. Radio treatment using protons. Next, we applied a halo body jacket for the next 4 months. The reason is I could not fix that fibular strut at the skull base with the appropriate screws, and I really feared it would dislocate. So I was confronted with a situation that you have one shot here, no more. So 6 weeks after surgery, you can see the fibular cup in place, and it's fixed with the small bone plates, and you can see the posterior construct, and you can see the halo here in place. And you can see that result. This is now 2 years after surgery, and it's with an ongoing cytostatic treatment. So this guy is coming in every 6 weeks, checking, and it's really perfect. We go on with this case. This is a 10-year-old girl with a progressive tetraparesis with loss of ambulation. She has a concomitant dysplasia, and I know my friend Mohammed Atala is an experienced orthopedic surgeon. So, Mohammed, do you have any idea what this could be from a point of diagnosis?
Difficult to tell.
I didn't get it.
Difficult to tell, actually.
Yeah. I thought maybe you have seen one of these or more of these patients in our hospital here. Now, if you know, you have this C-shaped kyphosis here and concomitant hip and knee dysplasia. This is a case in which the vertebral posterior aspects are not connected to the anterior ones, and typical for a so-called Larsen syndrome, which is a genetic disorder with numerous skeletal manifestations. And because the posterior elements in the spine are not connected to the anterior ones, you have a progressive kyphosis or olesthesis and a progressive tetraparesis. And that's why you just have to about in detail again in this patient. Surgery, yes or no, yes, what else? I mean, that's the reason why we're here. What levels to be included? I mean, you just check the X-ray and you say, okay, from the upper spine to the upper cervical to the upper thoracic, front, back, or both. I think back first, but front, let us see later on. What type of implants to be used? I mean, here, pedicle screws are great. Why? Because pedicle screws connect the posterior part to the anterior part. That's why here, lateral mass screws don't make sense. So you have to use pedicle screws here because the pedicle screws replace the function of the pedicle. And in case of using pedicle screws, navigation or robotics is a must. Atala, you know, most surgeons will tell you so. And a must, I don't know, because we do not own such a tool, and I do that usually without a robotic. The reason is I don't have one. Think about a patient in detail, part 2. The anterior aspect here is a hypomochlon acting against the spinal cord. And that's the reason why I call here for an anterior approach is high cervical spine discs will overload an isolated posterior fixation, and you have a space encroachment from the anterior aspect. That's why go from anterior here too, do an anterior resection of the space encroaching processes, do a correction, fixation, and fusion, I think, is a must here. Otherwise, it will fail. So I did the decompression, fusion, C3 to 4 using cages, autologous bone, and the plates. After surgery, she really regained walking ability. And you can see the MRI after surgery and the concomitant X-ray in the lateral aspect. Just a few final remarks to cervical pedicle screws. It's not a new technique. It's almost 30 years old by Abumi. The entry is very lateral at the upper edge of the facet. And the trajectory is characterized by a very high angle of convergence. You have a risk for vertebral artery damage. Just if you see that plastic bone, you can see it's true. That's why pedicle screws are best for C2 and C7 pedicle, simply because the vertebral artery is no longer medial. I strongly recommend to perform a CAT scan angiogram before surgery. You always have to do the good side first. The good side is the side with the thin vessel and the thick bone. And there is one major thing you should know. In case of vertebral artery injury, never touch the other side. Never do, never do. Finally, take-home messages. So posterior fixation to the C-spine is challenging due to small bone dimensions and the presence of the artery. Take into account that even routine surgery may develop into a big disaster. Never underestimate this. Perform a CAT scan angiogram before you start and do a biopsy in case of tumor. Fix occiput plates within the midline. Use lateral mass screws whenever possible. They are safer. Consider anterior supports in case of exclusively using lateral mass screws. Pedicle screws are great at the level of C2 and C7. If you plan to use pedicle screws between C3 and 6, be very experienced and or use navigation or roboter. Finally, plan your surgery. Plan your surgery. Work slowly and if necessary in an interdisciplinary approach. Thanks for listening.
Thank you, Tobias. As expected, it's a wonderful comprehensive overview for the pedicle screw and the lateral mass screw and the craniocervical junction. I think it's perfect for the three cases we will present. And we will put all the questions later on. The next, we just move on with the next presentation. And this is Dr. Atala Hassanain. He has been with us at first in Karlsbad, Langensteinbach, I think with you for 3 or 4 years, and then maybe for 5 years with us. And he is now in Riyadh, head of the spine section, a very new hospital, just started there. And he will present to us his, basically his research results for over the last 5 years about the particular insertion of the scroll into the lateral masses, so-called Atala scroll. So, Dr. Hassanain, it's all yours. Please start.
I'm trying to share, but I can't share it with you. I don't know why. Open system references.
Okay. Try to share. When you put share, you see several screens.
Fire off.
I know this guy.
I believe continue with the cases until I solve this problem, if possible.
Okay. Okay. So then I think I don't know right now which is the case for the craniocervical junction. Jason, is that your case?
I have a case for Atlanta.
Yeah,
it was
craniocervical junction, because I think it's best when we start with this case now, since we have not talked about the Atala screw technique, which will not be helpful for this case. So we start now with Dr. De Giannis. He is our resident in Homburg. He will present his case, which I think he carefully selected. It's a good case to discuss. So Jason, please start.
Okay. Is my presentation there? I've sent it. I need it. I don't see it currently.
You don't have a computer with you?
No, I sent it to the thing. I can also put on the computer when I need a moment.
It's better you give your computer.
Okay.
Because otherwise it's difficult to forward it.
Okay, one moment.
Maybe Atala, you fixed your problem?
About to.
If you put on sharing, screen sharing, then usually you see several screens, and the one with a red frame you select, and this one is who you're going to show. This looks good. Imad, thank you.
Sir, I'm sharing Dr. Jason with him. Yes.
Yeah.
Yep.
Okay. Share
Okay,
Jason's, and maybe Atala, you can send your presentation to well, best is to my Gmail account. Then I can forward it to Imad.
Okay.
Or you see
I'll
with
find
the
the Imad.
email I sent you, then he can share it. Okay, Jason, go ahead.
Okay.
Now you have to present.
Perfect. Hello, my name is Jason DeGiannis. I'm one of the, as Professor Ertel said, one of the neurosurgical residents at the University Clinic in Saarland. And today, first of all, thank you for the very interesting lecture to begin with. Can we get to the next slide? So essentially, I'm presenting a case with the history. The patient was reported to have cervical reposition. She had developed increasing symptoms in the form of a left-sided numbness in the hand area with slight motor function disorder. Furthermore, she also had recurrent pain radiating in her left arm. She was said to have fallen 3 days before. No higher grade of paresis was seen in the neurological examination. No sign of altered gait pattern, but she showed restriction of cervical movement, mostly in rotation. Inclination also, clear restriction. Next slide, please. So we had radiological imaging done, CT to begin with an angio to make sure that there was no sort of injury to the vessels. And what we saw was the picture beneath. So essentially we see that the dens is dislocated posteriorly. Further imaging was done. Can we get to the next slide? An MRI to show again the exact structures, soft tissue injury, and we saw that there was no injury of the vessels and no complete occlusion of the spinal cord. Next. Exactly. So essentially, we did a C1, C2 posterior fixation in this case. What I wanted to ask essentially with this, is there any sort of alternatives? Can you operate such a patient with no neurological symptomatology in an other way other than C1, C2? Would a C0 at any point be an indication in such a case?
Mm-hmm.
Okay, thank you very much. It's a nice case. Maybe Imad, you can go back for 1 or 2 slides to see the instability, to show us. Yeah, maybe one forward. Okay, here you see. Yeah, go back 1. Go back 1 to the MRI. The one before. Yeah. Which you did not point out very well, Jason, is that there was obviously a severe myelopathic signal just at the foramen, just at the back of the tip of the dens. And so although the patient has a very severe scoliosis, we did not really consider doing anything for that, but we thought that this is symptomatic. So what would your approach be, Tobias? Would you go for an occipital or just C1, C2 as we did?
Yeah, thanks for the question. Can you hear me?
Yes.
Yep. Okay. So I got a question for that. Do you have a CAT scan angiogram so that we can judge the course of the vessel up there?
Exactly. That was done. I think it should be on the second slide with the CTs. And we saw that there was no high riding vertebral artery or anything in that case.
Yeah. And the lateral masses of C1 have been so solid bone as we expect.
Exactly.
In a guy like that.
Bone quality was good.
Okay. Yeah. So what we saw on that is, what I saw, the first thing I saw is the enormous congenital scoliosis. So there are several hemivertebra that result in that terrific scoliosis. And what we saw is that usually the segment C1, C2 is reacting as a consequence of the scoliotic deformity. Usually it's reacting in the left-right direction. Here is reacting in an anterior-posterior direction. The thing is, what I want to say is that this is probably an epiphenomenon on the scoliotic deformity. But now you have a severe problem in the spinal cord at the craniocervical junction, so you have to treat it. I would not, to answer your question, Joachim, include the occiput. I would just exclusively do it C1, C2. But after having done that, I would think about a possible correction of the C-spine or the upper thoracic spine. Because I could imagine that
thank you.
The segment is overloaded. Yeah.
Exactly. That's my concern, is that the C1, C2 will become unstable over time because there's too much force on it.
Yep.
But we will see. It's I mean, for the emergency procedure, I think it was good to address C1, C2.
Yep.
But in the long term, it might become might need a little bit more extensive.
Yep. Can I ask a question in that case? Yeah. Do you apply a intraoperative neuromonitoring for this case?
Jason?
Yes, I see that there's no downside to, obviously, due to the localization of the compression, obviously use neuromonitoring intraoperatively. I mean, it's a tool, and if it's available, definitely always a good idea in such a case.
Yep.
Yeah, we always do motor.
Just go on.
And
I don't think we can hear you, Chef. I think you're cutting off.
All for extremities with motor and sensory.
Yeah. Okay.
Well, I think it's presentation. What do you think? Okay, so Dr. Hassan, all you. At least I cannot hear you. Abdallah, you have to switch on the unmute you.
Okay, yes, you hear me now.
Yes, perfect.
Oh, yeah.
Okay.
Finally, it's working.
Start. Yeah, now. We were looking forward to your presentation.
Okay, we'll talk about Atala screw. Actually, there are several known techniques for stabilization of the posterior cervical spine. The most commonly used, and will continue the most commonly used, is the lateral mass screw. The other alternative is the pedicle screw or the laminar screw, which is usually reserved as rescue technique for fixation of C2 and C7. The main advantages for the pedicle screw, as Dr. Betsin said, is that it's relatively longer in comparison to the lateral mass screw. It provides more stability, more biomechanical strength. The pull-out strength is very high, and it's very useful actually for complex deformities. So surgeons, expert surgeons, prefer to put always pedicle screws when they have very rigid, stubborn deformity where they need a good hold. The main disadvantage is that the learning curve is very high, so not any specialist, I would say not any spine consultant is allowed or will feel comfortable to put a lateral mass screw, a pedicle screw, because of the risk of vascular or neurovascular injury. Mm-hmm. The main problem, from my opinion, is that for us spine surgeons, we can deal with all complications, but having a mal-positioned pedicle screw bilaterally, or even at least on the dominant side, will result not only in a mal-placed screw that need to be revised, but with a patient that is not going to wake up after the surgery. So this is a complication, a disastrous complication for the patient and for the family, for the surgeon himself. The lateral mass screw, for the lateral mass screw, we have about 7 published up to now techniques for insertion. I myself, I never saw a single colleague who is adhering to one of the techniques. It will be written in the operative reports that he inserted it based on Magel or Harms or Roy Camille or Anderson. But in reality, we spine surgeons will always look for a good bone, enough bone to insert the screw, regardless of the angulation and the degrees. Mm-hmm. The complications what can happen with lateral mass screw are relatively of low incidence. So even the spine surgeons with relatively not much experience can insert safely a lateral mass screw, at least from C3 to C6. The main disadvantages are you can insert only short screw for unexperienced hands, 10 to 12 millimeter, and the most experienced hand, 14, 16 millimeter long screws. It's relatively safe. Bony purchase is quite low, and you cannot depend on lateral mass screw alone for correction of difficult deformities. And of course, it's difficult to revise intraoperatively. If you break the lateral mass screw intraoperatively, you can forget about that level. This is one example of cases which I call rigid or difficult deformities. This patient has severe kyphosis, known to have neurofibromatosis. He has undergone maybe 12 surgeries up to that point, and he's coming with this severe kyphosis. I myself, I really will feel very unconfident depending on 12 or 14 millimeter lateral mass screw to hold this deformity. So we realize that we have a problem. We need a solution. Why not to find a different screw? If pedicle screw is very dangerous, difficult to learn, serious in unexperienced hands, and lateral mass screw is quite weak, we need an alternative. So we started from the 0 point. We went again studying the human vertebrae, cervical subaxial vertebrae. We analyzed the anatomical structures, and we noticed that this is the lateral mass. Actually, we have to know that lateral mass by medical definition, it's only the lateral mass of C1. So we say lateral mass screw, but C3s, subaxial vertebrae in general, they don't have lateral mass structure. But we call this bony mass on the lateral side as a lateral mass. So we realized here that this is the pedicle, that's the lateral mass where we insert our screw. And this structure, which is actually the posterior parts of the transverse process, the transformed transverse process in the cervical vertebra, is quite comparable to the pedicle. In some specimens, it's even larger than the pedicle in the length and in the diameter. The idea was why not to use this structure for screw insertion. So this is the normal classical direction of the pedicle screw. This is the direction of the lateral mass screw, and this is the direction of the laminar screw. Here we compared the length of the pedicle, the maximal insertable screw length of a pedicle, to our proposed new trajectory. So our idea was to start between the junction of the lamina with the lateral mass, to go through the lateral mass and pass the whole way through the posterior ramus of the transverse process. In this image, we see the screws, the visual screws, lateral mass, pedicle, and atala screw. And you see, you don't need a study to say that the pedicle screw is comparable to the atala screw. One more important advantage of the atala screw is that we are not limited. You can notice that the lateral mass is limited to the posterior column of the spine. The pedicle screw is going through the posterior, middle, and anterior column, and the atala screw is passing through the posterior and middle column of the spine. It's not reaching the anterior column, but it's providing theoretically more biomechanical stability. These are operative findings as an operative Excel showing the lateral mass screw, the atala screw, and the good inserted lateral mass screw. So what are the advantages of this technique? Obviously, you have more bony purchase. You are passing through more bony structures. You get more biomechanical stability. The pull-out is very high. When inserting an atala screw in one of my patients, and it's not possible to correct it. If you try to bring it out, I'm sure you will break the whole vertebra. because the screw is passing through very, very narrow structure, and it's not easy to bring it out. I never tried to, but I got that feeling when I tried to. The chances of injuring neurovascular structures are relatively low because you are shooting from medial to lateral. You are shooting quite away from the spinal cord. You have it under control, and you are shooting also away from the vascular structures. The stability is quite high in comparison to the pedicle screw. One more important advantage for deformity correction is that you have a very huge space here for placement of bone graft in comparison to lateral mass, where the head of the screw is occupying the whole lateral mass. In case of fracture of the lateral mass, for example, bilateral mass through lateral mass screw insertions, you can insert Atala screw, and even if the lateral mass break through the insertion, or if it's broken because of fracture, you still have a long pathway to hold the screw. We did our study and we compared Atala screw with pedicle screw and lateral mass screw, and Atala screw was quite comparable to the pedicle screw. Actually, to do that, we spent about 4 years collecting adequate, appropriate specimens which can fit to the study. Then we did the preparation. We inserted the screw as usual in the operating theater. When we divided the vertebrae from each other, and we studied every single screw separately. This is one simple example where you had the feeling, if I cannot depend in the presence of kyphosis. I believe Professor Bessin is one of the most expert surgeons in Germany with dealing with cervical kyphosis. So we decided here to put the Atala screw. I chose this image just to show you that how huge is the space laterally to place bone graft. And spine surgeons, we believe that screws will hold, but we don't depend on the screws. We depend on the bone effusion. This is why Professor Bessin used in the first case the bone graft. In the first case, in the crâniocervical junction. There's one more case with tumor. You know, oncological cases, tumor cases are quite different from degenerative. That's true, you can correct it easily. It's much flexible to put screws and put implants and distract, but you don't have the bony strength which will hold your implants. In this case, we decided to do anterior-posterior approach. We did vertebral body replacement, and we combined it with the posterior approach through the screws, and this is the construct at the end. We used Atala screws in the subaxial spine, and we combined it with the pedicle screws in the upper thoracic and in C7. The goal was to have different screws in different directions so that we get the advantage of the biomechanical stability of this construct to avoid the loosening of the screws in case that this metastasis progressed and destroyed the vertebra above and below. There's one more case with severe degenerative changes and myelopathy. Here was the discussion, should we go from anterior, should we go from posterior? This is always the discussion in spine, and nobody wins. Believe me, don't go on that discussion because we'll never win. The other side will never win. But we had the feeling that the spine is mobile enough. So I started posteriorly. I decompressed the spinal cord. I put my screws. I corrected the deformity as much as possible. Then I went from anterior and replaced the vertebral bodies. This patient is coming regularly to visit me in the clinic. She's very satisfied. She walked like a normal patient. We never realized that she had a huge surgery like this. This is the 3D reconstruction. Again, I combined the pedicle screw here with Atala screws so that I have a base here for the construct holding and supporting the cervical spine. Because in a previous study, in Carlsbad, we find that even if you were successful in correcting the deformity and stabilizing the spine, the head will still go anterior. So again, it's easier simply because you will start medially, not laterally. For the pedicle screw, you should go very lateral. in patients with a huge head, a huge neck, very obese patients, getting this trajectory, even if you are an expert surgeon, getting the trajectory will be very difficult. And if you are able to get the trajectory with your probing instrument, inserting the screw itself might be a challenge. The other advantage is that it's almost always possible. In one of the cases presented today earlier, there was the discussion of if you should do angiography for every patient before committing the vertebral, the pedicle screw insertion. Actually, books are saying insertion of the pedicle screw is always possible. I believe not, because simply in this case, you don't have a pedicle to insert a pedicle screw. And trying to insert a pedicle screw here on the left side will end definitely with a disaster. It's safer, so you are heading quite away from the neural and vascular structures. We published our cadaver study, our radiologic study, and our clinical study. And in this patient, which I presented earlier, I decided not to put Atala screw, to put the pedicle screw, not because I don't rely on Atala screw, but simply because we did not, up to now, we did not manufacture our own screw. And the available screws for the Atala screw are allowing insertion only of small diameter rod. But if you put pedicle screw, you can use the thoracic and lumbar screws and combine it with a 6 millimeter rod. Thank you very much.
Thank you, Atala. Wonderful presentation.
Yep.
And the biggest compliment I can give you is that we will continue with your technique.
Thank you very much.
Okay. I think we should move on to the next case and discuss the next case, because I think we should finish all the cases and then have a discussion open for everybody. So the next one who's going to present is Dr. Al-Daher. Are you ready? Dr. Al-Daher is a board-certified neurosurgeon, and he is particularly interested in spine. Are you there?
Yeah, Chef. Hello zusammen. Hello, everyone.
Yeah.
Do you see my...
Please start with your presentation, buddy.
Do you see my Bildschirm, my monitor? I think so. So
At least not yet. Not yet.
Mm.
Screen sharing, and then...
Yes, I did it. Okay, we'll see now. We'll start then.
Then you usually see several screens and select the one with the red frame is the one you selected.
So Bildschirm, then yes.
Yeah, that looks good now. No.
Okay, now.
For a second it looked good. But what happened? Now it's gone again.
Okay, now it's okay.
I don't see it.
We see you.
I am sorry for the...
Maybe Imad, can you also just share the presentation with us?
But I don't have this one.
Are they all three on the same? They're all three in the Dropbox. I uploaded them myself. You don't have access to the Dropbox? Shana, send us the Dropbox. All three are in there.
Mine as well, please.
I just checked this morning. They're all in there. You have it?
Okay.
I just need a minute, sir.
I think now you could see my...
Okay, then
Yep.
now it's yours. Yes.
Super.
It's just a little
Finally
bit,
good.
just need some time.
Okay, so now I think you start. You can see my screenshot. Hello, everyone. My name is Fadi. I am a specialist in neurosurgery in the department of neurosurgery in University Hospital of Saarland. My boss is Dr. Joachim Ortel. So we will start with this case. It was a patient with 52 years old male. He came to us after he jumped in the swimming pool with a small amount of water while he was under the influence of alcohol. This resulted in an immediate onset of paraplegic symptoms. Upon the arrival of the emergency physician, the patient was found to be in a state of spinal shock, necessitating the administration of catecholamine. The examination, the patient was in an incomplete spinal cord injury, sensory from thoracic thoracic spine 5, motoric from C6. Clinically, we found here biceps and triceps weakness, both sides grade 3 from 5. Both sides have complete hand and hip plagia, and both sides have knee extensor varices 3 from 5, and right side has foot, left and knee extensor varices 2 from 5. Both sides have foot drop and knee flexor palsy. Both sides have a hypostasia of the elbow and hands. And here we see the radiological examination. The computed tomographic scan showed fracture of the vertebral body C6. So we did the surgery. First of all, we did carburectomy, and after that we do posterior fixation with lateral mass screws. Is the post-operative radiological study. Then I will come over to the question to the board. What do you think? What is the main indication and contraindication for lateral mass screw, and what do you think about lateral mass screw in C7? And describe your method in setting the lateral mass screws and potential complication and percussions.
Thank you. It's a good case. I think the first question to me is it possible to do it only from anterior, only from posterior, or you have to do 360 degrees? So Tobias, you're the first one to comment, please.
Thanks for that. You can hear me?
Yes, yes.
Yep. Okay, I would first like to see an MRI, and I would like to have answered if the posterior ligaments are disrupted. Is this the case?
Actually, we did.
I think we had no MRI on this case.
You know,
the problem is on weekends,
yep.
Although we are a university hospital, we sometimes are not able to get an MRI.
That's right.
So
we
I know that
operated
problem.
midnight, in the mid of the night, and we started this surgery first of all from anterior, and then.
Yep. Yeah. So I would have started from anterior also, especially if I don't have an MRI. The reason is if you have a traumatic disc prolapse, which could happen in that case, then you should get that prolapse first. I probably would have done a corpectomy. I probably would have done a cage with a plate. No, definitely would have done a big cage with a plate. And yeah, if I don't have an MRI, I probably would have turned around the patient and do the posterior instrumentation, one above, at least one below, but I probably would have not inserted a lateral mass screw in C7 because usually the C7 lateral mass is not existing. Yeah, so I would, so and yeah, but this is just probably because I don't have the MRI. So not having an MRI is to go the safe way. The safe way is not to provoke an additional prolapse. So if you don't know, if you don't have a prolapse, then you go from anterior first, make it safe, turn it around. So probably, Joachim, to answer your questions, I would not go from posterior alone, maybe from anterior alone, but then I would like to have an MRI before. So if I don't have the MRI, do it 360.
And would you also always decompress from posterior?
Yeah, I think so. Yeah, I think so. I think so.
Yeah, it's a neurosurgeon's perspective.
Yeah.
Wonderful.
Yeah. I think it makes
I doubt
sense.
that any
Because
orthopedic would agree with that.
I think it makes sense because you don't know what's in the depths of this spinal canal. You don't know it because you don't have an MRI. And I mean, I think this is the situation all over Germany, maybe all over the world, hopefully not, but it's getting worse and worse. And as you said, we don't have the MRI also, not at nighttime. So that's it.
I think we will address the questions from the auditorium from the later on in 5 minutes with the next case. Maybe just then, Atala, what is your thinking about this case? I mean, you might have noticed, Dr. Hassanain, that actually the lateral mass screws, they look pretty much like Atala screws. When you Fadi, can you share the screen again with the last post-op post here?
Yeah, of course, Chef. So I make the presentation. So
the last screen, you see that the head of the screws is very far medial, and this is the only disadvantage of the Atala screw technique, that you have to do the decompression before. You see that here, right? So the head is very far medial, so you might not be able really to address the lateral spinal canal after placement of the screws. Okay, so Atala, what is your idea? Dr. Hassanain, please share us your thoughts. Not responding. Okay, we lost him.
Okay.
Nothing we can do about it. Maybe, okay, then we move on to the last case. Dr. Al-Ghamdi, you have a laptop available, or are you have...
Unfortunately not.
Imad to
That's
share
why.
the screen. Imad, can you share the screen? Yes. Okay. Dr. Al-Ghamdi is a fellow with us from Saudi Arabia, and he is particularly interested in spine surgery as well. And his presentation is about the cervical-thoracic junction. So we have addressed craniocervical. Now we have addressed the cervical fracture, and now we go to cervical-thoracic junction. Dr. Al-Ghamdi, please start.
Thank you so much. Thank you. Hello, everyone. Thank you. Thank you for that nice talks. Hi. Thank you for giving me this opportunity to present today. My name is Osama Al-Ghamdi. I'm one of the fellow here at the University Hospital in Saarland. With the focus on the posterior fixation of cervicothoracic junction, utilizing pedicle screw. At the same time, could present our institute. So next slide, please.
Next slide, yeah.
Yeah, thank you so much. Thank you. So this male patient happens to be in his 80s. He presented in our emergency department with progressive ataxia, anterior paresis. His past medical history was known to have had prostata CA, which was operatively managed 10 years prior to the presentation. On the clinical neurological examination, the patient shown to be awake, alert, and fully oriented. The motor examination, we've seen at that time the paresis of the upper extremity, which was worsened on the later course. Otherwise, he was neurological intact, including the cranial nerves. So we proceed with our radiological imaging. On the left side, we see in the CT the massive destruction of the upper cervical spine and the craniocervical junction. On the right side, we noticing in the MRI, which revealed significant stenosis caused by a lesion involving the bones. One more, please.
I cannot see MRI and CAT scan.
Yeah.
Imad, next slide.
Yep.
Yeah, yes.
Yep.
Thank you.
Yep. Hoppla.
Can we proceed with the next, please? Seeing the bony destruction of the upper side revealed a significant stenosis caused by this bony lesion, which resulted in substantial compression of the spinal cord. So here, our approach involved a staged surgical strategy. So the patient was primarily underwent anterior fixation and corpectomy, which went very nicely and good. And on the following day, we proceeded with the posterior fixation. So it was like run a bit long from C0 till TH3. So the patient, after all, tolerated the procedure very well. The post-operative course was somewhat, however, complicated due to development of pneumonia and episode of delirium. Nonetheless, the patient was eventually discharged into the neurological rehab. So we're coming now to the last slide, please. So here are the questions which would be should be truly thoughtful of and addressed once addressing and tackling such cases. The first one, I would say, what are the anatomical challenges of thoracic and cervical pedicles placement? So the first question. Secondly, what are the specific risk factors for screw loosening or pull out? And what are the surgical techniques or tricks to overcome or reduce these risks? Third and last, how do these pedicle screw fixation techniques in thoracic and upper cervical region compare to other stabilization methods, namely like wiring or in terms of biomechanical stability and clinical outcomes? Thank you all. Thank you.
Welcome.
Thank you. It's a very nice presentation. Maybe, Imad, you can go back to the MRI. Can you go back to the MRI?
Yeah.
Yes.
Wow.
And the thing you did not address very well, I think it was the histology was, we thought it might be a metastasis from the prostate cancer, but at the end it turned out to be aneurysmatic bone cyst, right?
Yeah.
Is that right, Osama?
Yeah.
And that was the reason. That was the reason
Yeah.
why we did such a long construct, because the
Yeah.
bone was really, it was like paper. It did not.
Yeah.
You know, you did not face any resistance during the procedure.
Mm-hmm.
Okay, very nice case. So what do you think about this case, Tobias? And about the questions?
Dramatic.
Go back to the question.
Dramatic case. So, I mean, an ABC in an 82-year-old guy, that's really seldom.
Yeah.
I
did not believe it. I told the pathologist it's wrong, but at the end he was sure.
Yeah. So, well, that's. I mean, usually it's in children and very young adults. But before I answer your question, just to learn, because we're all here to learn, what approach did you use to get that devil here? What anterior approach?
We used anterior approach. We did more or less a standard approach. We did not use transoral. At the beginning, I thought about transoral, but it was possible only with a standard approach, ACDF approach.
Wow.
Yeah.
And the dysphagia after surgery?
Actually, the patient remained intubated. Then we did the posterior.
Yeah.
And then he did a tracheostomy. So we don't know about this dysphagia. Probably there was some dysphagia. We have to be honest. I mean, this is a huge, I think, 3, 4, 5 level corpectomy, and there must be dysphagia.
Yeah. Okay. So concerning these questions, can you give me the slide number 5 again? Yeah. Key anatomical challenges of thoracic and cervical pedicle screw placement. So is it meant for just for this case? or in
Generally,
general?
No, in general,
general.
in general.
In general, well, you have to be lateral, and you have to make sure that you know the anatomic landmarks, which are in the upper thoracic spine, the lateral processes, the transverse processes, and then we do it in a freehand position. We just open the cortical shell and then use a probe, or I use a 2.0 drill, and then just the cancellous bone gets me in, and then I palpate it, and in the C spine, I usually think if you go between C3 and C6, you should have a neuronavigation or even a robot. If you do it at C2 and C7, it is a pan-field dissector number 2. You place it at the medial aspect and you drill. So that's it. That's the way I do. And it's so classic freehand. The reason is we don't have a navigation, and nobody in our department wants one. That's it. Specific risk factors for screw loosening or pull out in the cervical. Well, I think it's the bone quality. First, if the bone is too bad, then you have lost before you started. That's why I usually say if it's an elective indication, so just ask the patient to get an osteoanabolic treatment of at least 3 months. So you can use teriparatide or zoledrone acid, bisphosphonate, stuff like that, and you will have definitely better results. That's at the time proven. The other thing is you should apply a fusion mass. Most surgeons just tend to say, okay, I have titanium screws or whatever, and I get them in, and then they are worrying why after 6 months, especially in the upper thoracic spine, they are broken. The reason is they don't apply fusion mass. So I strongly recommend apply fusion mass and refresh the bone using a sharp drill or chisel. So just prepare the bone for your fusion mass and vice versa. And how do particular screw fixation techniques in the thoracic compare to other? Well, they are more difficult. I mean, the pedicle is smaller, and especially in the C-spine, you have the neighborhood of thecal sac, 2 roots, and 1 vertebral artery, and it can be a big mess. I think in the lumbar spine, it's except L5 can be challenging due to the inclination, but I think it's the presence of the vessel in the C-spine and small pedicle dimensions. These are the key points you have to look at. Yeah.
Thank you very much.
Does that answer?
Dr. Hasanain, you're back. We lost
Thank you very much for your presentation, but I have one objection. Dr. Usama said that the presentation, the anterior approach was pleasant. It was not pleasant.
No. It's not a pleasant approach. That's true.
And regarding the, I believe not only the question is not regarding cervical and thoracic pedicle screw, but it's regarding this transition zone between the cervical and the thoracic spine. Actually, all transition zones in spine are difficult. So cervical, cervicothoracic, and lumbosacral are difficult. The only one which is easy is thoracolumbar. It's not only the insertion of the screw which is different, but you have to take care about other things. For example, the blood supply for the skin and subcutaneous tissue in the cervical spine is very limited. So you should take care while opening, while closing, keep the soft tissue to avoid disastrous complication, and that to end with the vac machine for 1 or 2 years. The second point is the bone structure. If you operate on the cervicothoracic junction, then you have to take care that the spinous process of C7, T1, T2 is prominent. If you have at the end of the surgery the feeling that it's prominent, so cut it now, don't wait until the patient comes with a prominent process where you need to remove it. Inserting the screws, you have to keep in mind there is no single patient which is exactly the same for the other patient when you're taking the trajectory, especially of T1 and T2. These are very difficult screws. Challenging here is that you cannot insert large diameter screws, you cannot insert long screws. So T1, T2 maximal can put 30 to 35 millimeter long screws. The next difficulty is how to combine cervical system with the thoracic system. This is not easy with all systems. Do you have a transition rod, which I personally don't like because they always break? If you want to use single rod on both sides, so you have to decide, should I put large screws with large trolben or head of the screw, or should I depend on the transition systems where you put small diameter screws in the upper thoracic and small diameter screws in the lower cervical and combine it with 1 or 2 rods? you definitely need bony fusion here. And don't forget that it doesn't matter how good is your system. If you don't have support ventrally for your system, your system will definitely fail. So don't rely on in this transition zone only on the posterior instrumentation. If the spine, if the spine itself ventrally is not stable, it will not hold.
Thank you. So I think what we should do, we should address the questions of the participants. Let's see what we have. Well, the second case, the question was, what was need for posterior decompression? That's a good question. Maybe Tobias, you can address this, because you said you would also decompress. The C6 fracture was the question. Why would you go for posterior decompression as well?
Okay. What I said, well, thanks for the question, Joachim. What I said is I would decompress in the non-presence of an MRI. So if I don't have an MRI, and I cannot judge the soft tissue situation in the spinal canal, then I would decompress just to be safe that I have decompressed. If I have an MRI, I probably, and I would see, okay, the spinal canal is just compressed via anterior, then I would not do it. But the thing was, in this case, you did just miss the MRI because it was at nighttime, which is okay. So, and then just to be safe, do a 360-degree decompression. That's the only reason. If you have an MRI and you see it's free from posterior, don't do it.
Yeah. But also we have to have in mind that this patient had a severe tetraparesis. It was not complete, it was incomplete tetraparesis. So these are the patients we have to, really go for and do everything possible, because those are the ones we can do who will benefit from a decompression. Even if you do a decompression in a case which is not required, just for the better be safe and do it. If it was complete, it's different. If it was no deficit, it's different. But if in an incomplete tetraparesis, I think it's a strong argument in favor of adding a posterior approach.
I mean, there are guys who would even open the dura and widen the dura in cases like that. I mean, a couple of guys would do that. I mean, I fully agree.
Atala, any comments on this? I think he has problems with unmuting. Okay. So there's another question from the chat. The trajectory of how placing the screws in patients in difficult situation like obesity. Well, obesity, it's a good question. This is something we did not address because we in Homburg we tend to do rather small approaches, and in Karlsbad I think you tend to do rather large approaches. And one big disadvantage, in my opinion, of the small approach is that in everything where you need an angulation, you tend to be too far straight, so don't angulate enough. So this is the same thing with the Atala screw technique and with the pedicle screw technique, although the angulation is exactly the opposite. But it's you have to pay attention not to have a too small approach. What is your opinion about that?
I mean, I sometimes do an extra approach, which is much more lateral, as I did for the Magal screws before. So I have a midline approach, and if people are too obese, then I do a very lateral, just incision, and just go with the instrument down to the entry point. You can do that. It's not a problem. It's at least a lot better than to press the tissue in an enormous way and producing a wound infection or a wound necrosis, stuff like that. So I mean, we are facing these patients, these obese patients, more and more. And I think a good option is to do a lateral additional incision.
Yeah, there are some companies, some systems which actually provide like a separate sheet for insertion of lateral screws, so for an extra portal. So this might help a lot in obese patients.
Yep.
I have a question for Dr. Betson.
Yes.
My friend, hi.
Hello,
Nice
hi.
to hear you.
Don't tell me that you have done. Don't tell me you have done
still
this.
sound the same.
Thank you.
Sorry.
This case with Larsen syndrome. Don't tell me that you have done it without traction, preoperative traction.
No, I can say I don't know. I think we applied preoperative halo traction. I think we applied. Do you remember? Has there been a halo ring in the X-ray before? I think yes. Usually we do that, you know that, because I mean it gives you time and a millimeter space or so. Because at least I know a lot of patients who just who benefit from the halo traction, the halo gravity traction. So it's not sense making just to apply a halo body jacket, but to apply the ring and then apply a halo gravity traction, and then it corrects a little bit, and you get a little bit more space. Maybe they improve a little bit in their neurological state, and then you can do surgery. But I fully recommend it, you know.
And what type of bone graft have you used, anterior and posterior?
The classic, we always do local bone graft, sometimes mixed with allograft. I cannot remember when I opened the iliac crest for the last time. It's a long, long time ago.
Thank you.
You're welcome. Could you please give, Joachim, I have one question to that guy, because today I tried to give him a phone call and the old number I have is no longer valid. It would be great if you send me, then I would give you a call. It would be good.
Okay. Okay, so wonderful. I think we had a wonderful session. I think there are no other questions in the chat. If somebody is interested in our work, feel free to contact us. And you can contact us through the World Spinal Column Society, or just in the Hamburg University, or in Karlsbad if you want to contact Dr. Pitzen. But Dr. Pitzen is difficult to reach. So
is that true?
Yeah, very difficult.
Difficult.
I give you my email and I will forward it. So it's joachim.oertel@uks.eu.
I got this.
Okay. Thank you so much. Thank you, everybody. Thank you, the two presenters and the 3 case presenters. And well, we meet next time. Thank you very much. And see you soon. Bye-bye.
Safe travels. Bye-bye. Bye. Thanks a lot. Bye.